So thank you so much. Sorry for the delay in getting started. As I was quipping, I mean, it was kind of a sleep stress test. We were seeing if you could stay awake while it was dark and kind of boring in here. So we'll see if we can keep this going and keep you awake during the entire time that we're here. But in case you do fall asleep, I put the conclusions up front. So, I mean, you know, myotonic dystrophy is obviously, as you are all expert and aware, a very complex disorder, and it affects sleep in many ways. We're still understanding them. It's very complicated, and that's part of why we're going to focus on that here. The breathing side of myotonic dystrophy definitely has to be addressed, and we'll talk about that. But there are aspects of just brain function. The brain is what tells you to go to sleep, and it tells you to wake up. There are areas of the brain that are responsive and responsible for wakefulness and sleep. I mean, it's a very restorative, should be a very restorative aspect of your day. And so it really is important. And that's why abnormal sleep affects all kinds of things. So it's very confusing for us to figure out, you know, what's actually causing what in this condition, because if you're not getting good sleep, that can affect your thinking, and it can affect your mood, and it can affect everything. So as I mentioned, we'll talk about the breathing, and then we'll talk some about this focus treatments, but I got to put it in the context of you know, the overall picture of what's going on, the genetic condition, because I do want you to at least be aware that this is a part of myotonic dystrophy that we're very hopeful is going to be responsive to some of these new, you know, kind of fancy treatments that are coming down the pike. So sleep is not separate from that. Sleep is part of the targets that we're looking to treat with these new treatments. So I do want to ask a bunch of questions. This gets a little personal sometimes. So if you don't want to talk about yourself, you can talk about somebody else you've heard of with myotonic dystrophy, but it gives me a sense of, you know, kind of how common this is. So what can I see a show of hands of people that have any kind of sleep issues, that it's a part of what they're living with? So it's pretty common. And it can be, again, it can be somebody that you know if you're not affected. I mean, you know, but just it's a part of this. And oftentimes my experience is that it's the other family members who can notice it as much as the person that's experiencing it. That's not always the case. Nothing is always the case in this condition. But I definitely have had situations where I'm talking with a patient in clinic and I say, do you have any sleep issues? They go, no, I'm like one of the world's greatest sleepers. You know, I'm fantastic. And, you know, their spouse or parent or family member is sitting there pulling their hair out and saying, you know, are you serious? You know, we got to talk, you know, because from their standpoint, it's more of an issue. So yeah, this affects a lot. How about fatigue as opposed to sleepiness? That pretty much is. Well, that's a great question. They oftentimes overlap, right? That's going to be one of my points, is that it gets to be really complicated to differentiate these things. Some people, and partly that's just how you appreciate things, and partly there's probably an underlying mechanism at play in this. How about what I'm calling here interrupted nighttime sleep? And this can be all kinds of things. You know, just waking, is that common or not as common? Pretty common. You know, this is also, we can dive into in every one of these things. Now, the next one might not be as obvious to you, but there are people that really don't have a 24-hour clock. You know, it's almost like I mean, most of us have experienced some kind of jet lag, and it's almost like just being at home, you're experiencing jet lag every day. so that I mean, given you're on your own, you might sleep longer every day. You'd prefer to get up an hour or two later every day, or you'd go to sleep an hour or two earlier. So that's another thing that people have. Then the next one is what I'm calling brain fog. Does that ring a bell with people? And I would love to get anybody who's able to kind of encapsulate that more, kind of describe it for me, because I've had people tell me they can differentiate between sleepiness, tiredness, and brain fog, that those are all distinctly different experiences for them. But I think we run into language issues here. It's hard to describe them so that I really fully understand what that's like. Does anybody want to take a stab at it? But I'll try to encapsulate it just so that they know what you said, and I'll try to do a better job going forward. But it's kind of like your brain is filled with molasses. Everything is just moving slowly, and it's not clicking, it's not sticking. Maybe molasses isn't the best thing because that's sticky. But at any rate, it's going much more slowly. Let me ask a follow-up question to that. And that is, does that, and this can be you again, or it can be anybody else who wants to chime in. Does that description resonate with other people of what brain fog is kind of like? Yeah. Okay, so now the question is, does that fluctuate? Does that vary from day to day? So some days you've got brain fog and other days you're pretty clear. It can?
Yeah. It's not just day to day. Sometimes it's hour to hour.
Hour to hour. And say it again?
Depends on the task.
The task?
Yeah.
Huh, okay. I mean, that's really interesting. And is that a general experience? Is that it's an hour to hour thing, or is it more? No, other people don't experience that hour to hour fluctuation. Yeah, no, but you're the only one who knows what you have. So, this is why I'm asking. So I'm hearing differences here where some people really have something that really varies more during the course of the day. Some people have it pretty predictably for some parts of the day, and other people will have it even more randomly. So what we're hearing is that there's variability. There's in terms of the timing, and then there's this. It can be a loss of kind of awareness of where you are as part of it. It can be a loss of ability to communicate as part of this. My next question is there anything you can associate with what triggers it? Is it completely random, or is it if you really didn't get a good night's sleep, it's going to happen? My major point here is that there are a lot of ways to look at this, so that these things are all overlapping. So, and it's silly to try to think that we can, selectively tease out, what people are experiencing in terms of, all of these different symptoms. So tiredness overlaps with sleepiness, overlaps with brain fog, overlaps with fatigue, overlaps with other things that we'll talk about. But, that's part of why this is such a challenge for us to really get our hands around and do a good job of understanding, let alone treating. So I'm going to go through some things here to try to make sense of this. So we're going to talk about sleep and myotonic dystrophy. And really, I view this as part of both types 1 and 2. And I'm sure there are going to be differences once we drill down and understand this better. But I think for first approximations that we can and should be thinking of this as being something that can occur in both, because Lord knows I've heard about the issues in both. So I think that's true. So I'm going to talk about abnormal sleep, but I'm going to start back in the genetics. And I'm going to go through this really fast, but just to remind you, and it's just to make the point ultimately that even though we're talking about the far end of the spectrum, I mean, it's really hard to study brain fog in a mouse. Let me tell you, that is a challenge. And so these are things we can only investigate by talking to people that are experiencing it really and trying to approximate it in different ways. But we're going to start way at the other end of myotonic dystrophy and talk about the genetics, just because I don't want you to think that these are separable. It's all part of the picture. And we're trying to take a very holistic approach to this. So just to remind you that there are these two repeat expansions, and look at how quick we're going. They both from DM1 and DM2 cause those little pink globs inside of the cell nucleus. Those are abnormal. You should never see those things. Those are distinctly abnormal. And it's really quite interesting if you actually look at the dates of those articles when this came out. The pink globs were identified before we knew what the genetic causes of the pink globs was, before we really understood that. The genetic cause of myotonic dystrophy type 1 was identified in 1992. So that was identified. But how you got to the pink glob, that was not at all clear. And then, but it was, the pink globs were identified, and then the mechanism in DM1 was identified, and then in DM2. Also here, if you're looking at DM1 and DM2 now, but this was, also, this was published before DM2 was actually identified, before the genetic tetranucleotide repeat was identified in DM2. We already knew that those globs occurred. I apologize here, they're no longer pink. Now they're kind of chartreuse on the far left. It's just a different dye that's used. But the fact that red dot in the middle absolutely lines up with the little chartreuse dots on the left is the cause, is part of the problem here. You're getting abnormal distribution of that protein, MBNL it's called, it doesn't matter. But you're losing its normal function. And so that, we worked out and figured out, and this was fairly early on as well. This is looking at one of the genes that is screwed up because that MBNL isn't where it's supposed to be. So this happens to be the insulin receptor. And this happens to be a myotonic dystrophy type 2 muscle. Could be type 1, could be type 2, doesn't matter. But this one is type 2. This is the same individual who was biopsied twice, once at 28 and once at 36. And it's making the point that those pink dots, I mean, the blue circle in the middle, those are nuclei. In the left-hand side, they're the little navy dots. They're really tiny. So that each one, if you actually honed in and looked very closely at each of those little tiny dots. Oh, I don't have my mouse doesn't show up. Okay, each of the little tiny dots in the pink ones. So the two pink muscles, the little blue dots have been magnified many, many times to look at that single one on the towards the right there. And then you can see that they contain those pink globs that are abnormal. And then that leads to this abnormal effect on the insulin receptor. So the insulin receptor is screwed up. Maybe that plays a role in some of your muscle fatigue. I don't know. That's really hard to tease apart. But certainly that's the kind of thing that could be happening. And that is also going on in the brain. So this is just looking at the brain in its type 1 and type 2. We see these changes going on. And again, in the brain cells, you also get those little extra dots, and they're also sequestering that single protein, that MBNL, as opposed to someone without myotonic dystrophy in the bottom row. has no pink dots, and that MBNL is widely distributed. It's a cloud around the nucleus, but in the people that are affected, it gets sequestered into those pink dots. Again, I'm bringing this up just because I think it's relevant for you to understand that all of these things work together. This then shows you all of the genes. I mentioned the insulin receptor, but here we're looking at 1,000 or more, a couple thousand genes that are abnormal in DM1 or DM2, or in both DM1 and DM2. So you've got a lot of things going on here. This is what makes it so complicated, is that each cell that has those pink globs is getting the sequestration of that MBNL protein, which is altering a whole bunch of genes. Okay. And that's why we're getting this kind of number of symptoms that people have. All right. And this just shows you so that myotonic dystrophy comes in all flavors, from very severely affected infants up to minimally affected parents and in between. But the common element is that repeat expansion, that CTG or CCTG that's in everyone, and it's in every cell of everyone, and it's quite large, and it's sequestering that muscle blind. Now that, in fact, leads to a whole bunch of different challenges because it's affecting thousands of genes. That leads to changes in how the body develops. It causes some cells in the body to degenerate or fall apart earlier, age more quickly, if you want to think of it that way. It causes certain cells to just not function well. It causes that whole list in the middle. And then each of those things is affecting the skeletal muscle, and it's affecting the brain. And changes in the skeletal muscle, we're going to talk about, can lead to sleepiness. Changes in the brain can lead to sleepiness. Changes in the heart can lead to sleepiness. Changes in the eye, I don't know if they can lead to sleepiness. I don't know. I better stop while I'm ahead. But at any rate, it certainly changes in the gut can lead to sleepiness. I mean, if your gut is aching all the time, you're not going to be sleeping well. I can pretty much guarantee it. And so there are undoubtedly other ways that everything is interconnected. So there's a lot that goes on. So one of the things we ask every patient every time they come in to clinic is, what's your sleep like? Do you have any sleep problems? And here is a combination of myotonic dystrophy type 1 and type 2 patients in the red bars, asking them about different aspects of their sleep. So this is all about sleep. And the blue bars are people that don't have myotonic dystrophy. And the red bars are people that did, or orange bars. And you can see we talk about snoring a lot. We always talk about snoring a lot. But, people with myotonic dystrophy definitely can snore. But as you can see there, so can people without myotonic dystrophy. Snoring is kind of the common denominator. That's not unique. Okay. But these other things are really quite significant. So that stoppage of breathing, where you actually have an episode where you stop breathing. Now, don't panic. You'll kick in again. But if you have somebody sleeping next to you, it can freak them out. I mean, hey, you're forgetting to breathe. They'll rattle you to get you breathing again. It's quite startling for if somebody's awake and watching you. But you'll kick in again. I'm not worried about that, but it's important to be aware of. Look at the daytime sleepiness. I mean, it's just markedly different. So, so that myotonic dystrophy, again, type 1 and type 2, kind of across the board of a number of different things, and we'll talk a little bit more about them. Okay, so sleepiness and fatigue, we already talked about this overlap. There's a definite overlap there. We've all experienced fatigue that is just in your muscle. I mean, if you get really mad and go grab an axe and go chop wood for a while, your muscles and you are going to feel quite tired. And you can feel that. They can be just spent, but you're not necessarily sleepy. But there definitely, if you're really sleepy and you haven't been getting good sleep, your muscles can feel tired too. So there's an overlap there. But again, if we look at this, and again, now this is broken out for DM1 and DM2, and you can see I wouldn't put a whole lot of stock in that difference between DM1 and DM2. I think our numbers are too small here, but they're pretty comparable. As I said, I view these things as going on in both quite a bit. So, there's a significantly greater tendency for fatigue and a significantly greater tendency for sleepiness in myotonic dystrophy of both types compared to people without it. Okay, so when we're talking about myotonic dystrophy, the name of it is muscular dystrophy, basically. So we do have to start by thinking about the muscle and how that works. And there are a lot of muscles that are intimately involved in sleep. I mean, as I said, sleep is triggered, sleep is programmed by the sleep center in your brain, but it depends on the muscles doing their job. Okay, so there are a number of muscles in the throat that have to be working correctly to keep your airway open. Well, people that have an early onset of myotonic dystrophy, and for the most part, this is DM1 we're talking about now, because DM2 does not generally kick in that early, at least not that significantly, to cause this abnormal growth. But people are affected early on with myotonic dystrophy type 1 can have a much kind of longer face and a higher arch to their palate. Okay, that's very common, even in people that might not get diagnosed until adulthood. So that there are a couple of issues then. So for people that do have early onset or had early onset, they might have a more narrow throat, which is easier to block. So it's just that if you start out with a more narrow kind of aperture or opening there for the air to go through, and the muscles get a little weak, it's quite easy for that to block. Okay, so it's very common that these muscles. Now remember, when we talk about muscle in myotonic dystrophy, you can think of immediately two issues. One is it too tight? The myotonia, the muscle doesn't relax, that happens. Or is it too weak? The muscle is floppy and weak. Both can happen here. But for the most part, we're talking about the weakness side of this when we're talking about the problems with sleep. Now, how about the breathing muscles in the chest play a significant role here as well. So the muscles in between the ribs play a part in helping you breathe in and breathe out. The diaphragm is the main driver for breathing in, where it pulls the lungs down so it sucks air in. That's the way you breathe, is sucking air in by having the diaphragm go down. Okay, so that's cool. So all those muscles can be affected. What happens when you go to bed is you lie down. So this changes the anatomy here. Everything gets shifted by 90 degrees. And now gravity is going to be pulling some of those structures and muscles down more and making that airway even smaller. So it can reduce the size of the airway, makes it harder to get air in. What happens in terms of the breathing muscles is that, again, you're lying down. Well, the part of the chest that's against the mattress, whether that's your back or your side or your front or however you're lying, that the ribs there can't expand as well. They're being held by the mattress. So your breathing is all using the ribs that aren't being held by the mattress. I mean, you can get into the mechanics of this, right? I mean, you see what's happening. But the other part of it is that now gravity isn't pulling that diaphragm down the way that it is when you're standing. In fact, gravity is pushing on your belly, which is pushing your diaphragm up. And it's restricting the movement of the diaphragm, and that's restricting how much air you can pull in. So everybody, 100% of people when they lie down, are going to breathe more shallowly than if they're upright. Okay. Furthermore, as you get into sleep, you get more relaxed. Your muscles get even more relaxed. And when you get into REM sleep, remember REM sleep, this rapid eye movement sleep, the dream sleep, you see your dog and you can tell when they're dreaming, right? Is because their eyes are kind of bouncing around. And they might have a little twitching of their feet. But for the most part, they're not fully moving during their dreams, and neither are we. Okay. It can happen. If that does happen to you, that's something else. And that's an interesting thing. Some people do move during their dreams, and that's a different issue. But it's not common in myotonic dystrophy. So what does happen is that your brain essentially paralyzes you so that you're breathing. If you're breathing shallowly, just being up, maybe your muscles are a little weak. So if you do a breathing test, it's off a little bit. When you lie down, you're going to breathe even more shallowly. And when you fall deeply asleep, you're going to breathe even more shallowly. And at some point, your oxygen level is going to fall off. Okay. It's not worrisome. I'm not trying to scare you. You have mechanisms to correct this, but the mechanism to correct it is to wake you up a little bit. Your brain kind of senses that, and it kind of goes, oop, the oxygen level's dropping here. We better get you breathing a little better. It doesn't let you get as deeply asleep. So you can sleep for 12 hours, but you might never get to a deep, restful stage of sleep, or very infrequently, because your oxygen level, it just won't stay where it needs to stay. So that's why that's part of the reason why people with myotonic dystrophy have kind of crappy sleep oftentimes. It's because their muscle is not maintaining their oxygen level when they're kind of on autopilot once they're lying down and asleep. Does that make sense? Now, how many of you have been told you should use a BiPAP or a CPAP or something like that? It's got to be more than that. I can't believe it. Now, how many of you use it? Okay. Yeah. But that's the point, is that, congratulations for getting to use it, because it's really important. And the mistake many people make is that they focus on whether or not they feel completely well rested and restored by using it. That's their metric of whether or not it's working. And in this condition especially, I don't want to use that as a metric of whether or not it's working, because it's too important for your overall health. If you're not breathing fully because of all the weakness and positioning that we just talked about, then your lungs are kind of losing air during the night. They're getting more dense and more dense. There's not as much air in there. Well, the denser your lungs get, the harder it is for your heart to pump blood through them. And that obviously has to be happening continuously. And so it backs up into the heart, and that puts more strain on the heart. Please, I'm not trying to scare you. Talking about all these things can seem scary. And I really want to reassure you that I'm not talking about anything disastrous happening tonight. You're not going to dare go to sleep tonight after this talk. But that's not the point. These are things that evolve over time. Okay, so this isn't something to worry about, but it is something to pay attention to, because the heart's affected in myotonic dystrophy. The last thing we want is anything that's putting more strain on the heart, because that can change the architecture of the heart, and that can exacerbate some of the other underlying issues in the heart. So it's really good for most people if you go and they tell you that you're having these drops. They talk about desaturations during the night. Your oxygen level is dropping. That's the metric. We want to measure whether or not you've got a device that can help. Now, two other points. Hopefully there are no more than two. But at any rate, one other point is that people oftentimes use CPAP. Okay, that they start with CPAP. What's the C of CPAP? Continuous. What CPAP is it's just a continuous blowing of air into your face. Okay. Now, what that does is it makes it really easy to take a deep breath. I mean, most of us, if you've gone out in a really stiff wind and you face into the wind and you take a deep breath, you can feel it. It goes down to your toes. It just like, wow, I haven't had a breath that deep for a long time. It's really cleansing. It feels great. The issue is if you have weakness of breathing in, you might very well have weakness of breathing out. So that exhalation phase. Now you've got wind blowing in your face and you're trying to blow out and you might not be able to blow out completely. Well, if you can't blow out completely, your next breath is not going to come in very well, right? So using CPAP for somebody that has trouble blowing out can truly be suffocating. Okay, so that it can be dangerous that if you put this mask on, you get that one great breath, and then you can't get another breath because you can't blow out. Okay, so be sensitive to that. If you haven't found out yet, you're going to have to educate a lot of the medical professionals you work with. And we can bemoan that and we can try to fix that, but that's going to take time. And I'm all in on trying to fix it. We do a lot to try to fix it. But you really don't wait for that. I mean, you've got to educate yourselves and then be nice. I mean, tell them that, you had some other ideas of how this might play out. And that, that this CPAP thing, it just doesn't work for you. And that you heard something about BiPAP, and maybe that's really what you need, because BiPAP has, as you might guess, 2 levels. Okay, so it when you're breathing in, it blows in, and when you're breathing out, it actually blows in still, but only a little bit. And that's for mechanical reasons. So it makes and you set those pressures, you dial them in perfectly for one person. So we always want to focus on that part of sleep because it's always an important part of it. But the difference, I mean, you see ads all the time, right? For people, do you have sleep apnea? We can treat that and all these things. And that's great. But for people that don't have myotonic dystrophy, then CPAP might work. For people with myotonic dystrophy, you might need to go to BiPAP for that to work. But the medical profession doesn't always realize that. So this might be something where you need to help educate about what's going on there. So I hope that makes some sense. But, we always start there. But the other point I wanted to make was we're not going to end there. So we want to see those desaturations decrease during the night. Then we know it's working. But you might feel exactly the same as you felt before. You're going, good Lord, I felt so sleepy. That's why I'm using this stuff, is to make my sleep better. And I still feel terribly sleepy. This fool thing doesn't work at all. That's because you have 2 different things going on. You do have the breathing issue. Don't ignore it. It's important to keep your heart healthy, to keep your whole body healthy. But we can't limit ourselves to that. We have to focus on the other things that are going on. Okay. So what else is going on? And that gets us to the central nervous system. And I mean, this adds complexity to complexity. And I am not a sleep expert. And it's just, there's a lot going on for sleep centers and wakeful centers and different pathways and different treatments. I mean, you might have heard of using Benadryl to help you fall asleep. It's an antihistamine. It's a histamine blocker. But there's a new histamine blocker that actually wakes you up. So, I mean, this is confusing, and there's a reason for it. And the real smart people understand that difference. But, it just to make the point that this is a really complex system. And that's why it's just not one thing to do about it. There is something we do about it, though. And one of the things we oftentimes use is modafinil or Provigil. Now, I don't know if anybody in here uses or has used Provigil. You have taken it? I mean, have people stayed with it, or have they tried it and gave it up?
It helps a little bit, but then eventually the absorption.
Yeah. I mean, so it's complex, right? It's not a simple solution. And there's a whole family of drugs like that, right? That are various types of stimulants. And you might need that, and it might help you. I'm sorry, where? Oh, yeah, like dextroamphetamine. Yep, exactly. So, there's a number of these things that people try, and they can be appropriate. They can help with brain fog for some people, in addition to helping, with your sleepiness. But I mean, these are all, highly regulated drugs, so they need to be carefully, kind of doled out and managed, and it's not simple, but it is key. So just to mention a couple of things, because I think it's where the field is going. I'm blathering all over the place. So am I running out of time yet? No. Yeah. I mean, I know it's. Do I get an extra 5 minutes, 10 minutes? Okay. All right. Well, we'll try to muddle on. I'm not just gonna. Some of you all helped us in a previous. Oh, I have to make a pitch. Around the corner is our Stanford group. We're doing some really cool things in terms of video capture. It's totally non-painful research, but if you want to sign in over there, you're welcome to after we leave here. It's very cool. It's using artificial intelligence in multiple ways to try to analyze movements more than just with a stopwatch. How long does it take you to go 10 meters or something? We get a whole lot more information out of it. One of the things that some of you helped us with in the past is this one, where we were measuring brain waves. I do think this is going to come back, and it does tell us a lot about how the brain is wired and what's going on in sleep in part and in other things. And so that'll be there. But this just kind of summarizes the issues. And we didn't talk about all these things, but there, as I did mention, that sleep is really quite complex in myotonic dystrophy. The breathing part is a cornerstone. We need to deal with that, but then we have to move on, not stay stuck on that. But it is just for overall health really important to deal with. Okay, so how do we manage it? We talked about CPAP. Now, it's not, some people will tell you that CPAP, remember that's that simple one that's just blowing in, is never appropriate in myotonic dystrophy. I think that's too harsh. I think there are times when it really is appropriate, but it's if your breathing muscles are still strong enough. If again, it comes back to that, do you have any weakness in terms of exhalation? If you do, then we might not want to use that. We might want to use BiPAP. The reason that CPAP is the one we start with oftentimes is it's just easier. I mean, putting a mask on your face when you're asleep, as stylish as it is hard to get used to. So you do have to get over several hurdles here, to be able to actually sleep with somebody when you have a mask on. That's a challenge. But it's for your health. It's oftentimes an important part of it, and so take it a piece at a time, step at a time. So CPAP is easier because it's continuous. BiPAP can be harder to get used to because you and the machine have to be in sync. So you can't be wanting to exhale and it's wanting to blow air in. You're going to hate it. Okay, so we oftentimes have people get to use the machine during the day, while they're watching TV or something, you kind of just get used to it. And that can go on for months. I think the value of it's going to be during sleep. But that can be the hardest time to get used to having a mask on your face and syncing up with the machine. So anyway, there are tricks around this and it's important. And this just shows you why. And it starts with normal sleep and goes through that poor breathing. But you can see what we're trying to avoid on the far right there is that it really can lead to more heart damage and difficulties that we can't avoid. I mean, I've seen almost miracles in terms of heart function when we got somebody to use a breathing machine, right away. So it can be valuable, and these are some of the devices. Now, there are other issues here, and this is where it comes to these stimulants. There was a trial we did with expansion therapeutics that was looking at one treatment that didn't pass muster. It's not that's not being developed further yet, but I actually expect that to come back in other trials. I think the science behind it is very good, and it can be quite specific, I think, for what's going on in myotonic dystrophy. And then Harmony is also developing this. They're still in clinical trial, and we're eager to hear. I think, did they talk today? No, tomorrow then. So mixed results. And I think the issue in myotonic dystrophy is you're all unique individuals. I mean, I think that, we just have to start there because this is such a variable disorder. So I don't view any of these treatments as being, kind of clearing the decks on any of these issues. But, some might find some of them helpful. I'm very excited about it. But coming back to where I started, gene therapy could very well have effects on all of these sleep issues as well. And then we talked about hypersomnia. That's the excess sleepiness. That's the daytime sleepiness. But there's also a big deal with insomnia in myotonic dystrophy. Does that ring a bell? Do people acknowledge that? Yeah. And that's just this fragmented sleep. I mean, it's all elements of this get screwed up. And so, again, there are simple things to do. This is my colleague, Jacinda Sampson, who created this. I mean, and it's like, during the last few years, it's been hard not to have insomnia. The world's falling apart. So, how can you not experience it? But that's kind of joking about it. There are issues. And at present, we tend not to typically take a pharmacologic approach if we can avoid it. And so these are some of the common things you're going to want to do to try to limit your trouble with insomnia. But I know I really am running out of time now. So I think there's a lot to do. There's a lot that's kind of common management stuff. It's like every aspect of myotonic dystrophy. It's great to find somebody who knows a lot, but is also willing to learn a lot, because each of you is unique. Each of you is going to bring different issues to the table, and everything has to be tailored. There's very little off-the-shelf technology that you can just plug and play and make work for everybody. So that's what I wanted to talk about for sleep. And, I think it's a complicated issue, but I did want to reshare the conclusions in case you woke up again, that, you can remember why we're here and what we were trying to cover. So thank you very much. Happy to take any other questions. Oh, we have questions.
Is this working?
Yes.
We need it. So I have a few questions in the chat and we have
Okay,
questions
yeah.
for a few minutes because we were late. So the first question is, can you speak about the vivid dreams that overlap with reality?
Oh, what a great, oh, thank you. I love talking about that. I put that up on the initial slide. Does that ring a bell? Let me just ask. Nobody here. Yes? Oh, some bells over here. I mean, we had this meeting in San Francisco back in 2016 or something, and it was like wildfire. You know, so one person in the audience said, I have this happen where, yeah, I'm sitting on the couch and, watching TV. And I have to ask, the person watching with me, did I just get up and go into the kitchen and get a glass of milk or not? I don't know. Was that a dream or was that reality? It's and other people could attest to similar kinds of things where they just can't reliably. To me, this is somewhat of the fragmentation of this sleep cycle, so that ideally, you fall asleep, you dream, and your body becomes, paralyzed during the dream sleep, so you're not acting out your dreams. There's a normal sequence of how this should go. If that gets fragmented, you can have the dreams while you're still awake, and they're almost like hallucinations. They can be very vivid. I haven't heard that so much in myotonic dystrophy. It's usually when people are on the drowsy side, they're kind of dozing in and out, that they have it. Is that those of you who raised your hands, is that more what we're talking about? How about does anybody ever have their body just kind of fall asleep? They're just poof. I mean, it's just kind of,
I do it all the time too.
and it can happen where people are still awake and alert, but their body falls asleep. Like I was saying, when you get into that REM state, your body is turned off. I mean, the brain has mechanisms. It doesn't want you acting out dreams, so it paralyzes your body. You can sometimes trigger that paralysis circuitry, even though you're still awake. So this is what I mean by this. It's very complex and fragmented. Again, I don't want you to worry about this, which is why I come back to the genetics of this. I am optimistic. Now, if I weren't optimistic, I would have probably packed it in many years ago. But I am optimistic that with gene treatments coming up, that a lot of these things can be corrected. I think to me, that's going to be very, very exciting, because we think that a lot of the problems are due to neurotransmitters or neurotransmitter receptors or ion channels in the brain that are all being abnormally processed because of that repeat expansion and the muscle blind sequestration and all that. So remember those couple thousand genes. Well, all you need is a few of those to be neurotransmitters, and you can explain a lot of these things. So we'll see how it all plays out. You probably wanted a 2-word answer to that, and I gave you about a 10-minute answer, but. Okay.
Do you want to answer 4 questions?
Oh, I'm game. I'm.
Okay, so somebody is asking, so are you saying that the myotonia in the muscle biopsy gets worse with age? If I had no sign of myotonia in a biopsy 10 years ago, I might have some today.
So myotonia is only measurable functionally. It's not something we can really see in the biopsy. Okay, so myotonia is a physiological functional change, and that fluctuates. We don't see it very much in severely affected kids. So that's its own kind of interesting feature. But once it comes on during age, it can fluctuate. You can have periods of time where it's a problem and then it goes away. It's very variable. So I can't really predict that. That it definitely can come on later in life. Should we take a question inside? Okay.
Yeah, we do have like.
Now we're using the microphone. So again, apologies to people online for not doing a good job at that.
So I have an 11-year-old with childhood onset.
Yeah.
And a 4-year-old with congenital. They've never done any sleep studies.
Well, I mean, I mean, how are they doing? I mean, do they have, is their sleep pretty standard?
It's hard to say.
Yeah.
I don't have any unaffected kids. So.
Yeah, but I mean, do they go to bed at a reasonable time of night and wake up in the morning and stay awake all day?
Well, the 4-year-old still around.
Still taking a nap? That's not outside the norm. I mean, but
So it doesn't need to be a standard.
it doesn't have to be. I mean, you know, we in our center, we try to at least have the kids seen by a pulmonologist once. That's a goal. And they can assess, you know, whether they think, oh, the kid's doing great. You know, they don't really need a sleep study. The reason to do a sleep study in that instance is if you think there might be some degree of breathing insufficiency. It turns out that, especially in kids, I mean, a sleep study is one of the best ways of seeing if you have some loss of breathing function, because kids aren't really great at doing those silly breathing tests. You know, they're obnoxious for any of us to do them, but and kids are good at not doing things they find obnoxious. So.
I tend to go to sleep as soon as mid to middle of perhaps 4 or 5 hours. When I wake up, it's instant. I'm awake. There's nothing I can do then to go back to sleep. I get up, do whatever, and I can be like all day. It's me around about 3:30. I can literally have 2 minutes sleep and I wake up refreshed. And then that's amazing.
Yeah, I mean, this is part of this fragmentation of sleep. And it's an interesting phenomenon. It definitely happens. There's sometimes some kind of behavioral choices you can make. I mean, one of the axioms of sleep medicine is oftentimes get out of bed if you're not sleeping. You know, so like obviously you can roll over and see if you can fall back to sleep. But after, 30 minutes or something, you might want to just kind of clear the deck and go sit in the other room and, play solitaire until you're bored and then go back to sleep. But, it's oftentimes preached that it's not good to just lie in bed and toss and turn, because what you're actually probably doing is dozing off and waking up and dozing to a degree that you can't notice, but it's not a restorative sleep.